Okay, now we've been discussing some of the risk factors here. We talked about gender, right? Is race involved, or is ethnicity involved?
You know, people who are of European ancestry are more likely to suffer from this disease. We just don't see it as often in patients that are non-European.
Okay. What about other environmental factors? Is there anything that...
Well, smoking is the big one. Charlie also alluded to, you know, just a general state of health and exercise are also factors as well.
Okay. Now, we've got all these environmental factors, and we've got genetic factors. We've got age, right? Now you want to approach some way to manage and to track these folks from day one. So the question is, are you paying for tracking? Are they paying for getting all of this right? Or is there some kind of disconnect? In your view, from the payer's side, are you doing enough?
And unfortunately, in many areas, we don't have enough emphasis on outcomes. We certainly
What
have...
does that mean?
So there may be a lot of processes that are being well taken care of in the sense of, yeah, you need to come in for with the diabetic, a hemoglobin A1C every 6 months or whatever it is. But in terms of looking at the outcome of people who have been diagnosed with wet AMD, what happens to them over the next year to 2 years? And then if we find out they're not being well managed, what can we do upstream at the time of diagnosis to make sure that they are having better outcomes of their vision?
Go ahead.
Well, I think that's extremely important, and one of the things that I see as a great opportunity for a partnership between clinicians and payers would be to make sure that patients get frequent treatment enough. So we look at the results of the phase 3 trials. They're spectacular. It's amazing that Charlie and I can practice in the era that we do. We have a cure for neovascular or wet AMD, but when we look at what happens in the real world, and we look at a very influential paper in our field that was published looking at what happened in Europe, patients just don't have the outcomes in the clinic that they do in these clinical trials. And the main underlying reason is that they don't get treated enough. And it's tough. It's tough for family members to bring patients, for patients to come on a regular basis, to have these treatments in the eyes. And yet, I think it's important, if I'm a payer and I'm paying for this, I want to make sure that my patient's going to get the best outcome possible. I'm not going to want to spend money and then have a suboptimal result.
Well, let me, go ahead.
Well, Jared, when you say they don't get treated enough, do you mean that once diagnosed and they've begun on treatment, they don't follow up with the, you know, in terms of intravitreal injections, that they don't have enough, or that they never start on treatment to begin with?
You know, just looking at patients who start on treatment, quite often, unfortunately, we find that patients just don't get enough treatment.
But I want to cone in on
Yeah.
this. Let's first of all, I want to back up, because I've
Yeah.
heard a word that you rarely hear.
Yeah.
And
Is that cooperation?
No, no.
Okay.
No, that's unspoken.
Okay.
But the word I heard you use was cure.
Yeah.
Cure. Now, I've heard diabetic retinopathy
Yeah.
discussed, I've heard AMD discussed, and in the past, it was never cure. It was
Yeah.
always treat, it was always control. But you use the word cure. That's a powerful
And
word.
that's probably an overstep in the fact that, because when I'm speaking with patients, one of the main discussions I have with them is that this is not a disease I can cure, but it's one that I can manage. And in the past, people would go blind with certain. It was going to happen. You were going to lose your vision. Now we can stand in the gap and treat patients and keep people seeing. Over 90% of the time, I can maintain their vision, and more than 30% of the time, we can improve it substantially with treatment.
So let's be very clear. We're dealing with a chronic disease,
Oh yeah.
as are many other physicians
Right.
with many other diseases. But now there's an effective treatment.
Yeah, that's-
Not necessarily a cure, but
No,
if you can
You're accurate.
if you can keep people seeing whether or not you turn off the process, I'm not sure there's a distinction.
No, and there are certain patients certainly that respond in a way that they need less treatment.
Okay.
But for a majority of patients, this is a disease that lasts much longer than just a few years or even a few months.
Well, let me ask a provocative question then.
Okay.
Okay? How do you track the population in the sense of how prevalent is this disease in your group, in your plan?
So I couldn't tell you based on
knew
the
this was a
information.
provocative question.
Yes.
See?
But and I'd be interested with Jared in terms of what he would see as a active partnership. How could we better track those patients to, because, I mean, you're talking about a commercial population or a Medicare population, and in my organization, those are like two different shops, if you will. They're two different areas.
Well, you know, it's interesting that you bring that up, but I think we're managing a chronic disease, and I think once you see that a patient's being treated for this, then to go ahead and educate them, yes, you need to continue to follow up with the people who are
let me go
administering
back.
treatment. Yeah.
If you don't know the prevalence in your payer group, if you will, your payee group, does that actually imply that you don't know how important this disease is, that it hasn't, if you will, hit the radar?
Well, in all fairness, we do not fully understand the entire affected population for many different diseases. We'll have claims history, but that's oftentimes lagging in terms of the actual incidence of that disease, and we don't have necessarily, because people may come into our plan with a pre-existing diagnosis, that we don't have an easy way to track.
Okay, well, does this mean that it's under-recognized not just at the payer level, but everywhere? At the PCP level, at the payer level, the patient level? Is it just because we're just not paying attention?
Well, I think that's an accurate statement, but I do think that people have a lot of things that are vying for their attention, with regard to taking care of
My eyes
the
are
whole
right there at
patient.
the top for me.
I think for most people you're correct, but they don't always think of the primary care provider or their general doctor as somebody they can go to with knowledgeable expertise in that area. And a lot of times they won't even bring it up.
But is that fair? And by the way, is that accurate? Do people think they can't get good ophthalmologic information from their PCP because they can't?
I think it's challenging, certainly. I don't think that the
What a
primary care...
politic word that
I don't
was.
think that the primary care physician often does not have the tools in their office to be
Okay.
able to help. And that's why, having a partner, I certainly work with primary care providers in my area to help as a resource for that. And certainly there's a lot of things within my practice of medicine that I just have to defer to other individuals, and I need their help.
Yeah, we've spoken about primary care physicians, we've spoken about ophthalmologists, but we haven't spoken about optometrists. And many individuals, that's the only eye care provider they go to. Many don't even see a PCP for, general medical exams. So where does the optometrist fit in this?
So we do partner with optometry and general ophthalmologists frequently, but it's currently in our country, optometrists are not providing retinal care with delivery of drugs directly inside of the eye.
No, but if
Sure.
I may, isn't the point of the question really more people see optometrists than see ophthalmologists
Absolutely.
and PCPs?
Right.
And that is critical for screening, for picking these patients up, and for encouraging ongoing care. Because there's a disconnect. It's one thing to make a diagnosis, and it's another thing to manage these patients years down the road for their active wet disease.
All right.